Good morning, everyone. Thank you, Meera, for the compliment. Well, now, before starting the topic, before starting my talk, I like to put this picture. Look at this picture and tell me the diagnosis. This is a case where myself and another eye surgeon went wrong because without following the basic guidelines. This is the OCT of the patient. Patient is still with us on, and this is the FFA. Diagnosis, anyone want to comment? Okay, we'll move to the topic. And finally, I will come back to the diagnosis. I would say this one, in my opinion, I thought it is an inflammatory cause, inflammatory serous detachment with multiple leaks. And the FFA shows very clearly the leakage, a lot of leakage, which is not here in this one. And then, okay, we'll move to the topic. CSR is a choroidal disorder characterized by an idiopathic localized serous detachment of the neural retina on the posterior pole. It's a clinical diagnosis. Risk factors we all know is the stress, type A personality, corticosteroid, certain systemic conditions like hypertension and pregnancy. Pathophysiology, you know, is the problem is actually the spectrum of pachychoroid dystrophy, the earliest stage. You get thickened choroid, RPE dysfunction, and hyperpermeability of the choroidal vessels, and because of you get a lot of leakage, and the underlying cause and the assumed cause is elevated steroid, either endogenous or exogenous. And key features of the CSR or central serous chorioretinopathy is subretinal fluid accumulation and retinal pigment epithelial changes and choroidal vasculopathy, and this all contribute to form a nicely elevated dome shape, but still not, the height is not very high, but you can detectable elevation of the neurosensory retina in the posterior pole. Typical clinical presentation is middle-aged, stressful men coming with, central scotoma or a disturbed vision on the center. When the patient comes to you after refraction, their vision is most often 6.6, but you can see a plus 0.5 or a small plus correction on the affected eye. So you have to be careful before prescribing the glass if the thing is recent. The diagnostic techniques involved clinical diagnosis by examining, and the OCT is, you can easily diagnose OCT features, I will explain you later, and fluorescein angiography is gold standard only if you are going to treat the patient, otherwise it is not really necessary except in certain cases. And indocyanine green angiography, you can confirm the pachychoroid stress, the spectrum if you need. Well, now, my real topic is delineating CSR from inflammatory retinal detachment. And when this was given to me and when the program was sent out, quite a few eye surgeons called me and said, Salvin, this is not going to make, it's not important. Change the topic as delineating CSR from other serous detachment. I also thought it is right, but the topic was given to me by a uveitis specialist, my good friend Mirna. So Mirna usually won't mistakes at least in uveitis. So when I start making the lecture only, I realized the importance of this. This is an important topic. Why? Because it's very crucial whether it is CSR or other inflammatory conditions, because if it is another inflammatory condition, you give steroid. If it is CSR, you don't give steroid. So if you give steroid, if it is CSR, it becomes elevated. The first case that I showed you happened to me, so that is why it is important, and this is a common mistake that we all, most of eye surgeons experience, because the typical CSR sometimes you don't get. Well, what are the other inflammatory conditions that mimic CSR is the common uveitis conditions, VKH, posterior scleritis, infective focal choroiditis, white dot syndromes, a group of syndromes, you know what white dot syndrome group, but there are four entities which I am not going into details, and sympathetic ophthalmia. Well, these are not common, but when the CSR comes, you have to think of these lines because very often you get conditions. How do you delineate or how do you diagnose or exclude and isolate CSR from other conditions? First thing is history. History is very important. Well, I'm not going to talk about the systemic conditions now. For example, sarcoidosis also can present to you as CSR. But then when you take into the considering the whole picture of the patient, you ask those conditions. Weak age comes with other lot of other symptoms, headache, vitiligo and all that. Those things you have to keep in mind. And within 15 minutes, we are not going to discuss those things. But when you look at the fundus, so typically unilateral or asymmetrical, bilaterally. CSR, the history give a clue to you, typically unilateral. Most of the cases unilateral, but very rarely asymmetric, bilateral. But if it is symmetrical, you have to have a doubt because it could be something else. And painless, gradual onset, mild loss of central vision with metamorphosis. Not overnight, but slowly, not over days as well, but within a short period of time, patient says central patch of dysmorphic metamorphosia and a blurred or less contrast sensitivity picture, or else they will say disc-like elevated thing on the wall, mostly seen in males in their second decade and associated with stressed lifestyle, and as I told you in the beginning. And when you ask them to see what we used to learn those days, when a man is having a problem in the mind, which he cannot divulge to anyone. So severe stress, so we don't have those things most of the time. But when sometimes if you have something like that, then you can get CSR, so be careful. Look for history of steroid use is very important. Still, those are the features of CSR, but when you want to see the uveitis pathology, history is different. Often onset with pain and redness, photophobia, pain, redness, typical features of uveitis will have the patient, at least few of them. VKH white dot syndromes to be bilateral, though a bilateral, and posterior scleritis is usually unilateral, but patient is with severe pain. So you cannot make mistakes in that case. CSR will never cause pain. Infective posterior choroiditis linked to various systemic manifestations like I told you, sarcoidosis, etc. And white dot syndrome, especially APMPE, present with asymmetrically bilateral central or paracentral scotomas and blurred vision. And sympathetic ophthalmia, of course, you can diagnose, and they are also photophobic, difficult to look at that. Now, those are the history. So symmetrical middle age or the young age, one eye over few days, blurred central vision is more likely to be CSR, but bilateral, painful or associated with other symptoms and multiple most of the time you try to put into the other category or inflammatory. Well, when you do the examination, the acute CSR presents as serous detachment of the posterior pole with or without PED. Serous PED, very important, this one. Serous PED is confirmed on the OCT, serves as a marker for CSR. If you have a PED, very, very likely that it is CSR. If you remember the picture that I showed you on the first slide, there was even though it is kind of an atypical, but it has got a very nice PED. I would, if I, without trying to be so smart, if I went on the basic guidelines or basic principles, we would have diagnosed it as CSR. It's a chronic CSR which I showed you earlier. And sometimes chronic CSR may have a teardrop tract, like on this picture. You can have a teardrop because it's a breakthrough of this thing, and the exudative material can come down. And RPE tears occasionally seen with the CSR, and later it can give rise to neovascularization. And rarely CSR can present as bullous retinal detachment like this inferior area, but if you look carefully, you can trace the track up to the central area. This is important. This is, I have seen patients. Now, when you have an inflammatory serous detachment, you will have a kind of a multiple diffuse, you can see not like circumscribed in this case, and you can see fibrin under this But you can see fibrin even in the chronic CSR, but you see this, in this case there is no typical pattern. When you go to the OCTs, okay, look at this one. The OCT features of CSR is a very important thing, straight line, straight choroid. These are typical CSR. Rarely exceptions can be there because this is the extent of or a range of disease, pachychoroid dystrophy. But in CSR, usually it is straight line here, this one, choroid, and neurosensory retina is detached. But in the inflammatory conditions, you can see, undulating kind of a lobular-like choroid, lumpy choroid on the other than this. So this is more likely to be inflammatory, because the guideline that I went here is not a straight line, but here a straight line, so with that inflammatory. And now this one, serous PED, I told you if there is a PED, more likely to be what you call the CSR. Now this is a PED, so you can have, it has to be a CSR. But sometimes you can see fibrin under the retina, neurosensory retina in CSR when there is a breakthrough of the RP, but those are not diffuse. Those are, it comes coming from one point. You can see here is a breakthrough of the retinal pigment epithelium, and then it accumulates. It can become little wider, but you can always trace the point most of the time unless it's long standing, trace the point. So if you do the enhanced depth imaging or a more focus on the choroid, you can see choroidal thickening in CSR. And then the gold standard for the examination is FFA, but FFA you do most of the time if your aim is to treat. So when the patient comes to you, CSR, the management, I'm not going to discuss the management. We are not going to manage immediately, we are not going to treat, we are not going to do the laser. In that case, you don't have to do the FFA. Wait it for at least 1 or 2 months, so you do the FFA. But FFA features are the famous ink blocked or smoke stack appearance, this thing, so you can get in CSR. And this is very diagnostic as well as important for the treatment. But on the other hand, if you do a FFA on the inflammatory categories, you get delayed various kind of things depending on what condition. But generally, they have delayed choroidal filling, multiple pinpoint RPE leaks, and in arteriovenous in the arteriovenous place, and late prominent pooling of the dye in subretinal serous detachment, and optic disc is most of the time leaking, and it's called hot disc. Now, indocyanine green angiography we don't do for CSR, but if you are doubtful cases and if you make the confirmation, especially in chronic cases, you can see because pachychoroidal hyperfluorescence on the choroid in this area, because it is pachychoroid, as I told you, is it belongs to is subcategory CSR. So with that, I'm putting this one. Now look at this. You can see a CSR. Raise the people who says this is CSR. I will put another picture. So both cases, I don't know whether it is clear. Okay. In this case, I suppose on the first one, you can have the first picture on the right hand corner of this, the left hand corner, you can see the CSR, kind of a serous detachment. Anyone who wants to say it is, or want to say the diagnosis, it is not CSR, it is sarcoidosis. If you see, this is, but you see there are a lot of multiple white dots. So this is more of sarcoidosis. And the second picture as well, as you can see multiple whitish areas on the subretinal epithelium area. So with that, I'm going to go back to the first slide. I'm finishing because I have 1 minute more. Look at this one. At a glance, yes, it is inflammatory, right? So this you can have kind of a fibrosis as well. And then you do this, you can see the dome shape, you can see the straight line of the RPE choroid complex. You can see that it's still straight, and that one indication of CSR. And you can see the serous or retinal pigment epithelial detachment. Another, almost diagnostic feature of CSR. So this should be CSR. And then you do the FFA. Because I got confused with the fundal picture. Did the FFA, there are multiple leakage, but if you see very carefully, those leakages are coming from various points, but they gradually increasing. So it's a chronic CSR with multiple leakage. So we gave steroid because we couldn't diagnose, and condition became worse. Oral steroids. Okay, finish. Thank you. And then, so that is important. Finish. I'm just. Thank you.